So after the lunch session, this is some topic we usually do not talk about. Managing menopause. So to start with, first thing, menopause is a part of aging process, and it is perhaps biologically inevitable, and only the lucky group who survive till that age will usually experience it. So that's why it should not be stigmatized as a disease stage or as a hormone deficiency stage. Previously, the women, specifically in our country or the eastern part of the world, they are not that vocal or not that empowered to express their symptoms. But now, thankfully, they are also being taken care of and they are caring and they are asking for help. Fortunately, not all the patients or not all the women they have the symptoms of menopause during their transition. If you go by the data from whatever we have in the literature, around three-fourths of the women they usually have some menopausal symptoms, and of which one-third of them, that means around 25%, usually have that we consider as a severe symptoms for that they need some treatment. But the symptoms of menopause or symptoms which is cumbersome for the women for their day-to-day practice, they are usually heterogeneous. There is no specific pattern, and almost one-third of the women they have their symptoms even after a decade or half a decade of their menopause, and 5% of them can even have the persistent symptoms even after 2 decades of the onset of menopause. So there is no universal pattern. Grossly, if you divide the transition of the menopause from it doesn't come for a single day or single menstrual cycle like periods. So that's why it starts from -3, -2. They are classified in the research guidelines. Like initially starting with a rising pattern of deficit considered hormonally or decreasing age, and there is a prolongation in between the gaps between the successive menstrual cycle. So this is the start of the menopausal transition, and we call them menopause only if to go by the standard guideline, if there is 1 year has passed from the last episode of menstrual cycle. So age varies. If you go by the even epidemiological data in Western world, it is usually in the later part of their life, in the early of 50, like 50 to 51. In Indian data, it is in the mid 40s, that is somewhere around 45 to 46 in most of the studies that we did for the transition for the menopause. It occurs early in those who are found to be smokers or those who have a family history of early menopause or chemotherapy or radiation therapy with some other oncological factor. And the patient with hysterectomy, even with preservation of ovaries, they have a menopause earlier than those who have hysterectomy for both. And by guideline-based therapy, also we provide hormonal therapy for those women who are having cessation of menstruation below 40 years, but there is we call them as premature ovarian insufficiency or POI. And we also have a term called early menopause. We have a menopause beyond the age of POI, but before the average expected age, we call them early menopause. Diagnosis is not always as clear cut, like those who have intact uterus with a cessation of mens for more than 1 year and the age is more than 45 years. This is the most common epidemiological diagnosis. And those who have undergone biological salpingo-oophorectomy with or without hysterectomy, like those who have their ovaries removed. So these two groups have a clear cut diagnosis. Problem lies in the diagnosis in those patients who have the hysterectomy but not with removal of the ovaries. So there we have a HPS cutoff of more than 55 years, or in this group of patients, if medically indicated, then we can do a CDL, FSH, or MH, and if it is more than 40 in two occasions, usually taken as a standard for defining menopause in this group of patients. Major concern, why we are talking about menopause in these group of patients, mainly because of the symptoms they usually comes with, mainly in the vasomotor symptoms or the urinary symptoms of menopause, like commonly called as PSM or ESM. Also, we are concerned about the bone health. That is, we are considered to know about the postmenopausal osteoporosis and the decline in the bone health after menopause in women, and we have a dedicated session today later by Usha Shikam. We will listen to her. And we have also issues related to the sexual and cardiovascular health. So we'll go one by one and how we can help women in this irregular transition. So as per if you go to the latest guideline now, the approach to menopause or any treatment planning for menopause is definitely a sharing of experience between the provider and also of the patient. It should be a shared decision making. Overall planning depends upon the problem of the patients. Like all the patients will not have the similar problem depending upon the need. Some patients will have no symptoms, some will have some degree of symptoms, some will have the very severe degree, or some patients will have the more predominantly hereditary symptoms of menopause. So we should have an individualized approach. However, healthy lifestyle related to the diet and exercise applies for all. Grossly for the lifestyle modification, we usually give the advice for healthy diet for all, like for any non-communicable diseases or those for this group, this age group, irrespective of the gender. But one or two things that is we need to tell them specifically those who are having higher symptoms of vasomotor related like hot flashes. There should be reduction in the intake of caffeine and tea, and it has been found in studies that a daily caffeine intake of more than 200 milligram per day increases the more severity of the vasomotor symptoms. So that is one thing that is different in this group of women. And also exercise, definitely like other, it improves the cardiorespiratory function to create a calorie deficit so that there is less amount of this midlife weight gain. And also it helps sometimes to advise in the resistive training to improve their lean mass as well as it helps to at least delay or helps in helps to mitigate the decline of the age related BMI in this group of person. And it exercise like it helps in secretion of endorphin, it helps to reduce stress and also the depression or the psychological point of view to the menopausal woman. So exercise also we can advise them weight bearing high and low impact exercise like aerobics and running, but again we need to be cautious about if they have some issues related to the degenerative disease like osteoarthritis, there the high and low impact exercise will be difficult. In them that non-weight bearing and non-impact activities like swimming and cycling will be better. Resistance training exercise like weight bearing elastic bands is helpful specifically in geriatric population where the sarcopenia also comes in features. And for perimenopause movement, to be specific endurance exercise and exercise for all muscle group by rotation is important, and also we need to keep in mind like we should do as much as we can. So they should be cautious about injury and fall, and they should know their limitation and tolerance level also to exercise. Now coming to the specific complaint, mostly what we see in our clinics and mostly from the whatever we got referrals from the gynecological point of our colleagues, that is the vasomotor symptoms. So mostly these symptoms usually having hot flashes, night sweats, sleep disturbance, and to some extent mood disorder. Severity, they are usually called mild if there is a sudden sensation of heat in the upper chest and face, like in the localized part, and it is considered moderate to severe, though these are a little bit subjective if the symptoms are more generalized, lasting for more than 2 to 4 minutes without perspiration, palpitation, and anxiety. So these are usual the demarcation between moderate to severe and mild symptoms. More severe or moderate to severe hot flashes usually seen in African American and the western part of the community. Those who are having a sedentary lifestyle with high BMI, those who smokes with stress, anxiety, and other PTSDs, and those patients who are on ACRs. Again, the temporal pattern of vasomotor symptoms differs, and there is lots of heterogeneity. It can occur even before the cessation of pills, like in the perimenopausal period, the onset of vasomotor symptoms, and even most common is at the onset and immediately after the menopause. However, it can be seen, the onset can be seen even after 15 years after the onset of menopause. For the Asian point of view or the cutoff for the normal duration in Asian or eastern part of the world, the symptom severity as well as the symptom duration is less. Luckily, so most of the time in Asian women, their duration of symptoms is usually less than 5 years, rather than in African where it is almost 10 years. So there are various scores which can help them to differentiate between the severity of the scoring, severity of the symptoms. General measures like that we can tell them for both mild and moderate to severe, like they can use layer weights so that it can be when they are in the period of hot flashes, so they can remove one or two clothes, and there is breathable techniques, use of handheld fans, avoidance of hot rooms, avoidance of high caffeine related food or spicy food that can be helpful. Menopausal hormonal therapy, this is very specific, and I will go in details that it is given only in those patients who are having moderate to severe symptoms, and usually with the age of less than 60 years or within 10 years of onset of menopause, and those patients who don't have a clear-cut contraindication, mainly in the form of breast carcinoma as well as cardiovascular disease. For those patients, those who have a contraindication or those patients who are not willing for the hormonal therapy, we have the alternative of the non-hormonal pharmacotherapy as well as the other therapy like the CBTs, like cognitive therapies, hypnosis, and stress reduction therapies. However, most effective is the menopausal hormonal therapy. Now, the controversy related to the hormonal therapy comes up of the landmark trial, that is the WHO trial, the Women Health Initiative trial, which has shown like routine supplementation with the hormonal therapy post menopause increases the risk. However, further when the analysis was done, it has been seen that this risk is much less if we consider the early menopause, like the treatment period, which is just after the menopause, rather than the prolonged treatment duration more than 60 years of age. So to summarize, if you see, definitely there is chances of harm when you are using estrogen plus progesterone both in the increasing the risk of cardiovascular event, mainly driven by the increase in the DVT risk. However, there is benefit in the form of bone health, in reduction in the vertebral fracture, lung cancer when you are using both estrogen and progesterone, and when you are using estrogen alone, like those patients who doesn't have any uterus supports hysterectomy patient, so there also the risk of DVT is high, but we have a beneficial effect not only in the symptomatic but also in the cardiovascular event as well as the bone health, like bone fracture and as well as reduction in the rate of vertebral fracture. So it is not bad, rather it can be helpful when indicated specifically in those women who are within the first 10 years, who are in the younger cohort of the postmenopausal women. But we need to look for the absolute contraindication also. Any undiagnosed abnormal or vaginal bleeding, suspected history of breast cancer, if there is suspected mass and active DVT, these are the known absolute contraindications for starting any postmenopausal hormonal therapy. The risk is increased for hormonal therapy if the duration of therapy is more than 10 years, when you are giving the therapy even after at the age of 60 years, and those patients who are already having some comorbidities which increase the risk of complication. On the other hand, we can mitigate this, like we can use it carefully, we can reduce this if we use in the lowest possible dose, if we use transdermal route rather than oral route for estrogen therapy, if you reduce the duration of the therapy, if you use micronized progesterone, and whenever needed, if you can give only localized therapy of estrogen or other, like in the cases of genital symptoms of menopause. So these are the various hormonal therapy that we have for menopausal hormonal therapy. For the low dose, like commonly available now in the estridiol candidate, it can be effective in as low dose as 0.5 milligram per day. And there are two types of progesterone therapy we can give. One is the continuous therapy, one is the sequential therapy. For sequential therapy, it usually offered in those with younger perimenopausal women because they have a predictable bleeding. On the other hand, the problem with the continuous progesterone is that there is more chance of irregular bleeding episodes. We should remember that we should use progesterone in a dose that is proportional to the estrogen dosage. Like if you are using a higher estrogen dose, then the progesterone dose will be also sufficient to counteract the endometrial hyperplasia. And we do not need progesterone therapy if there is no uterus, that is post-hysterectomy patient, and also when you are using a local estrogen in the form of vaginal periods after surgery. In this type of cases, we can use only estrogen. So if you go by the last guideline related to the European society, so once the diagnosis of menopause is confirmed, either it is a historical or epidemiological diagnosis or post-surgical or hormonal, then we should give the in general advice on healthy lifestyle, food and exercise to all patients. We should look for the bone health in the all patients and manage it accordingly. Now those patients who are having the symptoms of vasomotor symptoms, like if the age is less than 60 years or within 10 years of menopause, we need to look for the different scoring system to see whether these patients are on the higher risk of breast cancer or on the higher risk of cardiovascular disease. If it is not there, then they are the candidate for the hormonal therapy. Again, if there is uterus estrogen, then we have an option of combined estrogen as well as synthetic progesterone or timolol, or we have ICMs like the C plus babedoxyfen, mainly in those group of patients who are having irregular daily episodes who cannot tolerate estrogen plus progesterone. On the other hand, those patients who are having moderate to severe vasomotor symptoms, but they are either having contraindication for hormonal therapy or they are not wishing for hormonal therapy, we have the other non-hormonal pharmacological therapies, like the most commonly used is the SSRIs and SNRIs, of which the maximum evidence is in the favor of paroxetine, and which is the only FDA-approved non-hormonal therapy for vasomotor symptoms in women. We commonly use the escitalopram, citalopram also. These are also quite effective among SSRIs. Among SNRIs, venlafaxine and dexvenlafaxine is effective. In the gabapentin group also, pregabalin and gabapentin has also found to be effective, and they have positive result in different randomized controlled trials. Regarding the evidence related to the non-pharmacological therapy, like this cognitive behavioral therapy and acupuncture, yoga, they have some evidences in observational studies, but not very robust randomized controlled trials, except hypnosis. Among the newer development, the one of the new drug that has been approved in last year, that is physolamine 10, which is a neurokinin B receptor antagonist, which is approved for vasomotor symptoms in women and mainly for those patients who cannot tolerate immunity or hormonal therapy. And we should remember that another disadvantage of using non-hormonal therapy is that they will not give you any protection related to the bone health. There are different troubleshoot we can face whenever we are giving the hormonal therapy in those patients where it is indicated and safe. Like if the patient is still having the severe vasomotor symptom, then we have to may require to increase the dose of estrogen, and that time we need to also increase the progesterone dose in a proportionate manner. Sometimes we need to shift the from the oral to estrogen or oral to transdermal if there is some related to the absorption that you can check with the estrogen level. If there is other persistent symptoms, we need to look out other causes of hot flashes also. Discontinuation is definitely difficult. Some people tolerate rapid discontinuation, some people they need a gradual discontinuation or prolonged therapy. That genital symptoms, again I will go very fast here, that mostly the first is the genital symptoms and sexual symptoms in the form of dryness and dyspnea. The first effective therapy is the local lubricants, and urinary symptoms, it is pelvic floor exercise or time fighting. If it does not work, then we have the local ultravaginal estrogen therapy. Even if it does not work, then only there is other options are coming, including the oral ospemifene, which is another approved drug for the dyspareunia. Urinary incontinence, stress, as well as urgency and mixed incontinence, it can be seen. Mainly, the therapy is behavioral therapy, pelvic floor exercise, and some drugs which can help into incontinence. Mental health is very much important. Sometimes we do not look into the change in hormonal level has impact in the patient's acceptance to this new life. And whenever it's indicated, we should refer our patient and we should help them for our psychologists or psychiatrists to help them to in these transitions. Dementia cognitive function, again, there are some studies which have shown some improvement, but it is not recommended for any improvement in the cognition or dementia, like this medical hormonal therapy as the evidence-based medicines. Bone health, I will not go in details because we have detailed session. Early menopause, again, as per if you go by the latest guideline, it is indicated till at the age of 45 years in all patients, specifically those who are having symptoms, as per the latest guideline from the United Kingdom. We should impair, again, it is very much important, like we should make aware and of the all the treatments which is available for their symptoms, and these are the different websites of which there are the first one, the Menopause, this is an NIH funded, unbiased, and not funded by any pharma industry, where the woman can directly give their symptoms, and there they will have their own idea what can be the different possible treatment options they can have for their different menopausal symptoms. So there are guidelines related to the workplace safety and workplace rights also during this perimenopausal woman. International guidelines, just to be summarized, the guidelines which are coming from the gynecological society, they are a little bit more liberal in the form of prolonged duration of hormonal therapy, but mostly the indication and contraindication remains same. For the guidelines from the endocrine society, they usually advise to be the hormonal therapy to be given in the for the shortest duration or duration of less than 5 years with a regular follow-up. So, as is just to summarize, women less than 60 years or within 10 years of their onset of menopause with severe, moderate to severe menopausal symptoms, they are usually the candidate for the menopausal hormone therapy. Women with early enough menopause without control contraindication, they should be offered hormonal therapy till the age of natural menopause. The risk of thromboembolism and stroke is lower with the transdermal therapy than the oral therapy. However, it is not recommended for the disease prevention, like for the cognitive or the cardiovascular disease point of view. Non-hormonal therapies are definitely an options for rheumatoid symptoms, of which SSRIs, SNRIs, and gabapentinoids are the most effective. And for women with only hereditary symptoms of menopause, usually the local therapies like local vaginal hormone and non-hormonal therapies are effective. So, thank you. We should remember like that most women will not require any therapy. So we should not over-medicalize it. However, we should help them to undergo a safe transition of their life, and we should remember that menopause is not a disease. Our aim is to help those who are having problems to embrace the transition more gracefully. Thank you for your patience.